Hello, welcome to my Journey to Oz Behind the Curtain video. It's amazing to see how much I've grown. I just got done watching my first Journey to Oz video. It's also amazing to see that I'm still not good at recording myself. So I know that'll improve, but I had to laugh that that is one skill that has not been attained at this present time. So I just got done watching my Journey to Oz video. It's amazing to see it's amazing to see how many questions I had when I was doing that first assignment and compare it to not only having answers but understanding my next steps in analyzing EBP. So I wanted to start off talking about what I learned this semester. It takes more than going to district meetings to really get evidence-based practice. In my first video, I talked about how that's the only way that I really do get evidence-based practice is when someone is giving it to me. And because I don't understand, or I didn't understand how to read research, how to compare and contrast research, the levels of the studies conducted, and why one might mean more to my clinical population than another. Am I even thinking about those things? And now I see that somewhat, even when I'm attending those district meetings, which I do annually, I consider myself a very supportive member of the NATA, NWATA, WSATA. But when I'm sitting there in those classes, I'm realizing I'm not really getting that knowledge. I sat in there to get the credit, check my box, answered the 2 questions that are required, and skedaddle out of there. And that's not getting EBP, and that's not allowing you to practice EBP effectively, efficiently, with a critical mind. I don't know if critical mind is the word I want. Like, with a mind that really knows what it's getting. I was once again caught in the role of receiving information and then just implementing it without asking questions and thinking about it thoroughly. I hope you understand what I'm saying. And it takes more. So it takes more than going to district meetings to get EBP. When I'm sitting in those meetings, I never focused on, what made this evidence-based practice. I didn't focus on the research that they put into it. The most I can think of ever getting, and it just speaks to what's really sticking with the audience that they're speaking to, is, did they explain anatomy to me or remind me of anatomy? And does that make sense to me with my limited knowledge of anatomy physiologically? And if it didn't make sense, or if I had critical questions about the physiologic component of it, then maybe I wouldn't do it. But if everything checked and, oh yeah, okay, yeah, that's the way the body works, then sure. I don't remember them talking about the hierarchy of studies. And I do not remember them ever discussing any evidence-based practice class I've been in, them discussing the population that it served and if that's applicable to my population. So those are things that I feel I have grown and learned in and have a reference point to move forward on. One example of that that I kind of want to bring up is in my previous video, I talked about how the way I knew that I felt comfortable practicing evidence-based practice in my clinic was how long the class was. So if the evidence-based practice class was only 2 hours long, I might not feel comfortable doing it. If it was 5 hours long and had 3 hours of hands-on work, then suddenly I was very, very comfortable practicing EBP. How do you even know what they're teaching you is evidence-based? How do I know that, this was shown to be effective in certain people? I didn't. I had no idea. I was a huge advocate for PRT. That was one of the longest evidence-based practice courses that I ever took. It was worth EBP credits for a certain portion of it. So I was a huge advocate for PRT. And then in this class, in this semester, I studied PRT myself, and I realized that, it might have some benefit with some lower level studies, and even proved to have some benefit in some RCTs. However, they, of course, because they're selling me something, never talked about how it was comparable to myofascial release, and that, maybe putting a hot pack on someone, unless you're short on time, is just as effective, or sometimes more effective. Those ins and outs were never presented to me. So it's interesting how I started this, really the beginning of this assignment, feeling very comfortable and feeling like I could analyze what made something attainable, what made something evidence-based, and what made me comfortable practicing evidence-based. And now I feel that some of the things that I have learned in those district meetings, I either recognize I'm not comfortable because I haven't practiced enough, or maybe it's that I am aware that there's other evidence, or I know how to understand their evidence, or I can press and probe and ask further questions for more evidence on what they're talking about. So that was one of the first things I learned. So I associated, let me scroll down here. Representing facts. One thing that I found interesting is when we talked about in the initial assignment, how do I use EBP in my clinical practice? I mentioned that all I ever did was what I was taught in undergrad, and that I didn't understand the important components of EBP, such as like what type of study validates that evidence-based practice. Is that exactly what I'm looking for? And again, not truly understanding the hierarchy of evidence. I was happy to watch the video and not see that arrogance on there. I think that most of the things that I have changed was not because I was arrogant before and I thought I knew it all. The things that I have changed, or I had questions before, and now I have answers, some answers now, and I'm happy for that. So what does EBP mean to me? Now, at this present time, after taking this one class, because I don't want to watch this video later and think that I'm being arrogant ever. So EBP means to me that clinicians are taking the time to critically analyze new research and ensure that it has significant and generalizable results that are specific to the population being treated, and that the clinician is incorporating that knowledge and practicing it to the best of their scope, not just to the best of their ability, but working to like the top of your practice. So if we are allowed to do certain things and you are in the environment to do so, and you are supported by your physician, and the evidence backs it up, there is no reason why we should not be doing those things. And if there is some reason that we should not be doing those things, then we should be active participants in changing those things. But that's a side note. It is more, evidence-based practice is more than just practicing skills that have evidence. It's being able to synthesize evidence pulled from several reliable resources, and then knowing when and how to apply that intervention. Another thing I've learned is I'm better at writing things down and then talking about it. It is so much more than just practicing those skills one or two times. I think about how I also just took a hands-on course, EBP course on, I think it was called like neural flossing or something along those lines, something that I had only ever heard of, and how I practiced those a couple times. Now, I was I would have been ready to practice if I had put it into my practice if I had gotten more practice in that class. The only thing that inhibited me from doing that is that, I need to read the book, or I personally didn't feel like I had a good grasp on it. But I never once questioned how much evidence had gone into this, how much it had worked for others. And if they were saying those things to me, it went right over my head. So I know I'm kind of beating a dead horse, but I'm proud of myself for learning that. I'm impressed with myself for learning that. And I feel I have been humbled to understand that there is more to learn. So how will I use that knowledge? The first thing that I have learned to do is synthesizing. And I kind of mentioned that's what EBP means for me. It's, I wrote a note in here, don't just stop at the first case report I find. Because any other time in the past that I made some general PICO question, it was Google the question, what comes up? Oh, look, here's a case study from a site that I recognize. Oh, it didn't work. Oh, it worked. Oh, I should do it then. That's not enough. What is the level of evidence? Does it answer my clinical question? And then what are other reports saying? If it is a lower, especially if it's a lower level, not a lower level of evidence. Well, a lower level of evidence, but if it has been set up to where I need to be pulling from different case reports and seeing, what are we saying as a whole versus a systematic review, that's something that I need to do. And then synthesizing the evidence to pull out what's important to me and weighing, not risk versus reward, but items of discussion on it versus what they have found. Are there questions I hadn't even thought of before? Is that question, are those missing pieces from that evidence enough to keep me from doing that study? All of that. I know that goes beyond synthesizing, but critically analyzing and synthesizing, those are things that I'm excited to apply in my practice now. Do I have the means and understanding to truly incorporate this method? So how am I going to use evidence-based practice in my clinical facility? I brought up this question of asking myself, do I have the means and the understanding to incorporate the method that I'm researching? Instead of just thinking, well, you don't know until you try it. That's not enough. That is not enough. It's going to help me. The first thing that's wrong with that is I was so focused on, well, if I can't do it, there's no sense in asking anybody else, or really utilizing other people's skills and building a stronger allied health circle. So I want to build that circle. I know that's not something that was necessarily, let me think really fast. Yeah, that wasn't necessarily taught in evidence-based practice. The class, I feel like we talked about that in one of the classes. I just can't think of which one it was. But through understanding the different components of evidence-based practice, I feel like I have I feel like I understand my scope a little bit better, and that it's okay to go out and rely on other people to fill, not the gaps, but fill the gaps. So that's important. The next thing I need to think about is my healthcare circle up to date? Are they up to date with evidence-based practice? Am I constantly referring patients to medical doctors wanting their insight on, I don't know, concussion symptoms that have lasted too long? And am I getting a note back that says they need to rest for 2 more weeks? If I don't understand evidence-based practice, how am I supposed to work with somebody else and really analyze whether they understand evidence-based practice? Are they promoting in the best interest of patients? And now that I understand those things and that I have a critical eye for it, I feel like I can be more, I feel like I have higher standards for who I'm going to bring into my circle, and that I can bring an intellectual conversation to other healthcare professionals and make the best judgment for the patients. I think that's really important. Do I need to add someone new to that circle as well? So if the people that I have now either I don't feel are up to date, or even if they're not up to date, that if they are not actively pursuing newest research and able to figure out, what's missing from that research, do I need to add somebody else to the healthcare circle for my patients? All things that I have now learned. What am I most proud of? Some key, okay, the assignment that I was most proud of was, besides, I am excited that I have gotten to this place where I feel like I have the building blocks to critically analyze research and figure it out. So I am proud of that. But one specific assignment that I was really proud of was the diagnostic accuracy infographics. I wish that I could put those on a readable one-page document with the same exact layout without spending a billion hours. I'm probably just going to print off an enormous poster because I want to keep the same work. But I am really proud of those. As a teacher, I know that this was the best type of exercise for me to learn from. I know that I wasn't looking forward to trying to understand the data components that we were given. The assignment was pick two, compare and contrast them. It was actually pick four and what they mean. And then I had to present it in a way that made sense to me. I wasn't looking forward to how much work that would take because I understood myself to know that I didn't understand those data sets. And so I was excited that I did learn a lot from that activity and that I was able to break it down in ways that meant something to me and then teach it, because I was learning probably as I was teaching, pose it in a way that makes sense to another audience member, pose it in a way that makes sense to another athletic trainer. I'm not going to promise that a whole bunch of other athletic trainers are going to see it. But I could be that person that posts on, hey, look, do you know the difference? But I was happy I did it. I was happy that I was able to break it down, and I was proud of myself for, maybe piquing people's interest into even reading it anyway. So I thought there was a lot of different skills that went into that project that I'm proud of. My greatest challenge was the clinical bottom line. I am frustrated to learn that with the PICO questions I have posed this far, the evidence hasn't ever really answered an honest question that I've had. It has always been, I have this question. These three things are in this study, but this was a really important part to it that I'm not getting. So now I got to go back. Is there any research that has all four? Is there research that I can couple with the other and make it answer this one? Has that invalidated it in some way? I understand I could still it's still a starting place for further research, but when you're sitting there and wanting an answer to your question, I was frustrated to find that the honest questions that I have are still not getting answered. I can't think of a question right now, but I know that it happened several times throughout this when we were asked, when we first asked to make a PICO question. Oh, well, that one was too specific, or, that one's too broad, or that's not comparing it to a gold standard, or, this is just a lower level of evidence, or this level of, or this type of evidence doesn't speak to patients. It just seemed like there was always some problem and some obstacle. in the way. So I was frustrated to learn about that when it came to I was frustrated to see that when it came to doing the clinical bottom line assignment, because, um, I wanted something that was answerable in my clinical practice, and I found myself altering my question to fit the assignment needs. And, that's not appropriate. Um, it's not real. It's not real life. So I was frustrated about that. With the assignment itself, because that's not the only challenge that there was. I know I need to get better at synthesizing evidence. I understand the principle of it, but I need to get better at doing it. I need to get better at pulling out analyzing what information is the most important, and picking up on those pieces to form a story that is going to best benefit me. That was my greatest challenge. Other questions that I have. Let me weed through these because I even answered some of them as I was writing these down. Okay, I'll just read it. In research that is up and coming, where only case studies have been completed, do we just base our decisions for validity on whether the design matches our problem? Nope, scratch that. I disagree. I disagree with what I was saying there. Okay. Let me pause this for a second. Okay, sorry, I had to read and cut out a couple things because I know how am I doing on time here? Yeah. Okay, so a couple of other questions that I have that I'm looking forward to getting more comfortable with, because I think that's what it's about, is something really basic. Understanding some of the differences in study designs is so problematic to me. For example, I had one of my peers when they were criticizing my abstract writing, ask me what the difference was between a crossover study and a cohort study. So I, get back on and I read both descriptions for the millionth time. And even now, like I can't even quite, I chose that it was a crossover study, but now I don't know if it's a cohort study. It's still bothering me that I don't know the difference. So I'm excited to get more comfortable with the differences between study designs. It's something trivial, but it is important. I just want to understand what that means. I'm also have questions about what the difference is between something being generalizable and something being validated. On my clinical bottom line paper, I received the critique that my study on post-concussion syndrome and how hyperbarics help post-concussive syndrome, or if they do, was that I had said that it was not, I had said that, what did I say? I said that HBO did not help, it did not prove to help people with PCS, I think is what I said. And the comment was made that, well, it was not validated, but it was generalizable. And I don't know that I exactly understand that. I can make, a guess, but I'll spare us the time. The fact of the matter is that there's a lot of times where things do look promising, and they always end the study in more research needs to be done. More research needs to be done, instead of just like, yes, this is working, or this is not working. And while I can agree that more research needs to be done, sometimes it would be nice to say, for them to just say, well, we trust where this is going, and, fill in the blank here. So anyway, I think that has to do with being generalizable versus validated, and I am just needing clarification on that. Also, so I think this kind of segues into my next thing, is the difference between a synthesis and a bottom line. My understanding is that a synthesis is drawing components from a bunch of different places and building a story with that. And the clinical bottom line is, with that story, Are we using it or no? Does it work or no? And I think between all four of those terms, I'm having difficulty understanding sometimes what the difference is between something being generalizable and something that is, yes, we can do this, validated. I'm still trying to figure that out. Let's see. I am still missing the downfalls. Oh, in my video, actually in the first Journey to Oz assignment, there was one section of questions that asked, what are the downfalls of only implementing evidence-based practice in the clinical setting? Or are there any downfalls? And if there are, what are they? I feel like I am still missing what the downfalls of only implementing evidence-based practice, what the downfalls are. I'm still missing that. I don't understand if something has been validated or generalizable, because I don't understand the term, why that's bad to only implement those things versus something that's shoddy, unknown, unresearched, and I myself am not conducting a research study on it, why I would want to apply those things to my patients. Is it because the alternative is doing nothing at all? Is that because the alternative is doing the same thing that's obviously not working? And where do you draw that line? If I was an active participant in an ISS, in a injury surveillance system, which I currently am not in, I could see why entering in those types of things that are not evidence-based might be helpful to the future. But if I'm not comfortable enough practicing something that's still not proven by evidence anyway, why? I don't know. I guess I'm just missing why that would be a weak point in my clinical setting, because I don't think that I would want athletic trainers doing that. So if there's something that I'm missing, I guess I just wanted to understand that component of, and analyze, okay, what are the pitfalls of just doing evidence-based practice? Because I don't understand. So thank you for a wonderful semester. I have learned so much. I'm excited to implement. I'm excited to grow. I'm excited to learn more about critically reviewing evidence for athletic trainers.